but I'm also the medical director of a complex rehab company that specialises in particularly trauma, high-end injuries, brain injuries and so on, across the whole of the UK and Ireland. So we have the joys of working across multiple health sectors and multiple health legislation areas. So I thought today it'd be useful if I could talk a little bit about actually what we do that's different, because the insurance sector, in particular that's where I'm based, is so very, very different from the NHS sector, where I spent the last 15 years working as a GP, and complete with all the frustrations that you get from working within the NHS. We're all familiar with the fragmented, complicated, difficult to navigate areas of healthcare that we experience in the NHS at the moment. It's certainly something that I have personal experience of, and I'm sure we all know people that do as well. So what we do is we use quite an extensive group of case managers, and so the question really is, why do we do that? I'll come on to talk a little bit about what a case manager does in a moment, but because it becomes very difficult for people with complex multi-morbid problems to navigate the healthcare sector, their care as a result is quite fragmented, and their recovery as a result is often out of sequence and also delayed. So, and given the fact that the role of the traditional GP, the role of the family, it used to you say, well, my healthcare coordinator is my GP, that person goes on to organise everything for me. Actually, that's very different now. We're lucky if we can get an appointment within 2 to 3 weeks with our GP. So, there's a big role in there for someone who understands the complexities of that individual's healthcare problems, whilst at the same time being available much more quickly. Interestingly, within the United States, health case managers have actually been used quite extensively for quite a long period of time. So the UK, particularly with its public healthcare system, is quite a long way behind. So what is a case manager? A case manager is someone who sits at the interface between the statutory sector, the private sector, the insurer, the solicitor, but above all there's someone who represents the interests of the patients and the patient's recovery from the earliest point in the journey of illness or the index. And so primarily what I'm talking about here is individuals who may have been involved in, say, a road traffic accident or an industrial accident, and they may have complicated, multiple, overlapping sets of health problems. And so a case manager is a clinically trained individual who has a background in that area that's the primary need of that individual, who will liaise with others. So for example, there will be someone who's a physiotherapist, someone who's an OT, someone who's a nurse, a neuro rehab specialist, sports therapist, and so on. So you'll get a large group of individuals working across all of those, and they will have access to and knowledge of all of the facets that might otherwise not necessarily be available from a single point of contact that you would necessarily get within the NHS. So the idea is that they will manage best fit, they will manage the sequence. There's nothing worse than someone being referred to physiotherapy who's got a broken shoulder and a broken leg, and they can't use their crutches because they've got a broken shoulder. So actually it's very much about understanding the individual needs of the patient in the context. So it's about championing the outcomes in particular. And one of the things that we can see by doing this, which is very different from the NHS model of care, our outcomes are far faster and the disease burden is far lower as a result of doing this. So where does that take us? Where are the gaps? So the first assumption that we all make is that the first time that we go and see a healthcare professional, they're going to know exactly all of the things that we need to do in order to get us better. That's not always the case. Often it will emerge or evolve with time that our needs, that the individual needs of that patient are very different after they've been in hospital, say, for a week or two, compared to how they were when they went in, or the first person that they saw. Indeed, the overlap, particularly between things like psychological illness and physical illness, is actually often not something that's particularly well understood in the acute phase of an illness, but has a huge impact on the length and the longevity of the recovery for that individual. So actually making sure that all the interventions happen in a fluid and appropriate sequence, it makes a massive difference. And you have to remember that by and large, the majority of these patients, they've never had this problem before. Their family aren't familiar with their problem. They can't advocate for themselves in this environment. So it's really important they have someone who understands it and the needs of the patient to make sure that they're accessing all of the right things at the right time, because they can't necessarily advocate for themselves. So what do we look at? Well, the majority of the high-end and complicated things that we look at are your catastrophic injuries that you'll see and hear about in the newspapers. We look after those particularly with traumatic or acquired brain injuries. And one of the things that we know, particularly with case management in complex cases, is that the earlier the case reaches a case manager, the faster they get better and the more complete their recovery actually is. The more you delay referral into a coordination service, actually the increase the cost is, whether that be disease burden or financial or otherwise. And so we're starting to see the benefits beyond physical rehabilitation. So that's your psychological, your patients who have particularly recurrent illnesses. So chronic back pain and fibromyalgia would be really good examples where actually intervening early reduces the complexity of these problems on a daily basis. It gives people the tools to manage their problems before they escalate into more serious issues. So I'm not going to dwell too much on this slide, but this gives you an example. All of the savings that are represented on this slide, which is the trajectory of recovery for someone who's got, say, for example, a knee injury, are benefited by the patient. The NHS, if they treat a patient from here or here, from here, won't realise any financial savings whatsoever. Okay, but the patient gets better 2 weeks, 4 weeks, 6 weeks faster than they would do otherwise. So that's a massive improvement. It's a massive improvement for the family, for the patient, for those around them, for the employer potentially. So that's why we're starting to see the use of these early intervention services. So we've spoken a little bit about this. So why use them? You get better faster. And importantly, to something that's relatively rarely understood, but actually the maximum achievement is also higher because you intervene earlier. And that has a huge bearing on why we do what we do, because in the insurance sector, long-term disability is an increased cost to the insurer for someone who's been injured in a litigation accident. So, but the NHS can learn a lot from that conversation. So yes. The other side of what the case manager does is they're always championing, they're fighting in some ways for the next best thing for that individual. But the patient isn't really necessarily in a position to talk to and liaise with the payer, so the insurer, so they can do that on their behalf. It's very difficult to navigate the care system, let alone the financial system that sits behind it all. So I thought I'd just quickly talk about case management in absence, because actually from an occupational health or from a disease burden for companies and corporates, actually it's really important. There was £77 billion worth of lost business last year as a result of absence from organisations. Okay, that's a huge number. And if you look at sort of absence rates, you're typically talking about 4 days per employee that's absent per year, which equates to around 1 in 30 people at any one time might be absent or ill. So, and it's important to recognise that this number is roughly doubled for statutory sector organisations. So, where particularly things like illness and sickness benefits are more protected, the illness rates are actually, and the absence rates are actually higher. So, what we've developed is a case-managed system to recover people when they report illness or absence at work that kicks in at day one. And as a result, we've got a lot more people going back to work sooner. So the burden for them and the financial implications for them is also much lower. And we do this through 2 routes. One is the group of people that are absent for less than 4 weeks, and particularly very, very early on in illness, because the earlier you do something, the faster and the quicker they recover. And those people that have been off for a long period of time, which is one of the sort of the hidden disease burdens of society. And we can do things that complement the work that the GP does. Signing someone off sick, assuming you can get to the GP within 2, 3, 4, 5 days, then we can do something that complements and say, actually, this person is able and capable of doing this, either with that or with that. Okay, so how would we help? If we do a case managed service for people who are absent on day one, we can reduce the amount of time that someone is off by 40%. Okay, that is a big number. Okay, medium-term absence, so that's people who are off work for up to a month, we can reduce that by 70%. Okay, this is not something the NHS can even begin to touch. It's, the NHS was set up to help people remain and stay in work all those years ago, and actually these are the sorts of things that it just has no ability to control. And then the long-term absence, that's your people who are off for up to, say, 6 months, around a 70 to 80% reduction in days lost there. But the important thing is that fewer than 50% of people, so 1 in 2 people who are off for 6 months will never return to work. And actually, if you can reduce that, you can reduce that. Big differences. So, what does that actually mean? If we reduce 70% of absence within the first 5 days of absence, which is the short-term group, you may not realise this, but actually around 70% of absence is in that short-term group. Only 30% of the absence is in the group of patients who are off for 20 days or 6 months. So actually, if you're looking at a traditional occupational health model where you're responding to the illness or the absence typically 2 or 3 months down the road because you waited for a report or something like that, you've already missed the window to prevent the escalation from 5 days to 10 days to 20 days to 6 months. So getting in there early makes a massive difference. So there's a big amount to learn from how the insurance and the insured sector handles this sort of thing. The HR burden on managing someone who's been off for 6 months is quite big for organisations. So what does that mean? Some numbers, thought that'd be quite useful. If we take a typical company with 1,000 heads, okay, there are organisations there that are much bigger, including the NHS. If you take the above approach to that and you apply it to the average day absence rate of £150, because that's how often the sector works, then you can actually see that traditional occupational health input, and there are other benefits for occupational health, so I'm not casting aspersions on occupational health, but case management costs more up front, but the benefits are huge because you're actively managing and changing the way that you manage the problem. Inadvertently, one of our customers said, our insurance premiums are cheaper because our claim rates are lower, because they take out insurance for people who are off for more than 12 weeks. Up to then, it's their own cost to manage. But after 12 weeks, it becomes the insurer's problem. But actually, they're making so many fewer claims, their insurance premiums have dropped. So the burden for that organisation is great because they've had an absence reduction of 70-odd% in their workforce. So they've got more people at work who are stressing the remaining workers less. And their insurance premiums, so they're saving money, they're having a more stable workforce and they're happier. So, but outside all of that, the patient benefits. You know, they get better faster, they are happier individuals, they've been looked after, they haven't had to kind of enter this disease model, they've stayed in a health model of care, and it very much it sort of remained in the presenteeism rather than the absenteeism sector. So small organisations can actually save a huge amount of money by doing these sorts of changes, but it's not something historically the NHS or indeed the healthcare sector has actually looked at. And then the statutory sector. This may sound like a rather strange thing to say, but the statutory sector stands to gain probably more than anybody from all of this. Not because it's money that they're going to save, but it's money that they're not going to spend. They're already spending the money. So the question is whether businesses would be wanting to do this or look at this, or whether the NHS should be saying, actually, case managers make the lives of GPs, consultants, patients better. Should we be doing this? Because it actually makes everybody's lives easier. The benefits for the social sector, for example, we haven't even spoken about, but you can imagine, you know, in terms of social support and the needs of, say, someone who's being cared for by someone who's been injured, suddenly there's massive reductions as well. So what are we doing next? Well, we are doing big bits of analysis with all the data that we've got, and we are starting to trend and plot. We're starting to trend and plot particularly things like why groups of individuals or populations of individuals have particular disease or absence rates and patterns, and as a result you can start to put preventative strategies in place. Joining all these dots together actually is incredibly useful, and we heard a little bit earlier about what the NHS, the NEL are doing with regards to population medicines, but none of that necessarily takes into account the individual nuances, right down to the level that an individual case manager would take with that individual. People talk about detailed small data rather than aggregated big data as being kind of an important step for the next few years alongside it. So really we need to be rethinking the way that we deal with absence and illness, not as discrete problems, but within the business and social context and the whole person. There's a lot to be gained. So I thought I'd just conclude really by just kind of summarising from a health perspective, case management actually improves the outcomes from complex conditions. It reduces the amount of time it takes someone to get better, and it improves the maximal achievement and the recovery trajectory measurably compared to standard models of care. So that's a big improvement. The amount of consultations they need with other third parties to chase, to check, to find, to do is removed greatly. And coordinating this improves the recovery dramatically. So that's kind of where case management, I think, should be really invested in and looked at within the NHS and statutory sectors. But these are quite advanced, quite well understood tools now. And certainly we've learnt a lot from the USA, where this has really formed quite a fundamental part of how they've managed their insured healthcare costs. And then, ultimately, the CCGs are already doing a little bit of this. So if you take, for example, the traumatic brain injuries or case review panels, where they might have 2, 5, 10 cases, every quarter where they've got that, they're not going to have enough of a resourced team to manage all of those cases in a coordinated way. They'll have a little bit of someone's time, maybe doing half a day or a day a week, but actually to dedicate all the time you need to get those individuals better. If you get a full team doing it, it actually works much better. And then lastly, by using case management, you can reduce the amount of time that someone is absent from work significantly, and the patient gets better, the company's happy, and the patient's happy. So hopefully that was interesting and slightly different from the flavour of the NHS conversations that we've been having earlier. Any questions?
Could you share any examples of, just an example of a case study that's gone through that process? Because it sounds great, but I just don't quite fully understand.
Sure. Are you talking about absence management, or are you talking about complex traumatic injury?
Maybe the complex traumatic injury.
So we look after lots of things. Some of them you will have seen in the news. Individuals where if you use something called the MD guidelines, which is a fairly well understood tool produced by Reed, they look at the expected recovery timeframes for individuals with injury X or injury Y. And you can actually plot the recovery journey for an individual against what you would expect to see for that individual. So be it a road traffic accident with a pelvic fracture, for example, you might expect someone to recover in something like 6 months or so. And actually, if you can get that person up and functioning and working better within 4 months, which is roughly the statistic that we can do, then that's a big benefit to the patient. They're better. The insurer likes it because the patient is less disabled than they would have been. So that's a sort of an example, but there's lots and lots of data, particularly in the American sector, where they've looked at tens of, if not hundreds of thousands of cases. For example, knee, which would be relevant for yourself, where you can actually see the ACL, the PCL, all the different reconstructions that they can do, and you can work out how long you would expect someone to get better, and how long, therefore, your intervention makes a difference for the recovery of that individual.
Is that data freely available?
It's not, it's behind a paywall, but I don't think it's that expensive. A lot of the data is, I think, broadly available because they do sort of webinars and things like that, which are published on their sites, but you do need a login to get to the actual, drill down to case type, injury type, age, and also they look at things like what the occupation is. So whether someone does a light job, a medium job, or a heavy job, for example. So you can track recovery based on the fact that they might be doing a very physical job as opposed to someone who's doing maybe a relatively administrative light type work as well.
It's a very interesting modality you got going here. Is this modelled after an American idea, or have we sort of done some innovation in it as well?
Well, there was never originally a place for case management in the UK because we had a nationally funded healthcare system. But as waiting times started to cause problems, insurers were recognising that their case claims were going up. So instead of something costing them 50,000 quid in a settlement, it would cost them 200,000 quid because it had taken the person 12 months to get better instead of 4 months to get better. And that's because that's the kind of the expected duration of recovery for someone in the statutory sector. And so case management kind of started in the late 90s, early 2000s in the UK, but it was really a niche. And it came over primarily from America. They learnt from the insured sector to say, well, this is what works for us as a health insurer or a general insurer in America. And actually, if we apply that in this situation, topping up the statutory services that are already available, does that make the same difference that we expect or hope that it will do in America? And the answer is yes, it was, and then it's kind of grown from there. Okay. I'll be quiet then. Thank you.